ready for the next session. I am not Darius Dudek. Darius couldn't make it because of COVID, so travel wasn't possible for him, but the designated chair, Darius Dudek, is with us somewhere in cyberspace and can hear and give comments. I'm here with Ahmed Khashaba from Cairo and Bilal Patal from Blackpool in the UK. And the session is about ultra-low contrast PCI in chronic kidney disease. What tools do we have? How to perform? How to achieve optimal outcome? How low can you go? Before we start, Darius, I think you're with us. Any comments on the way for us?
So happy to be together, and I think that we started almost 45 years, not me, but interventional cardiology with Andreas Grinting, and this session is ready to show you that the new technology and technique could completely change the way of approaching the PCI. So I am very curious for this session.
Great. Okay, without further ado, Bilal Patal will tell us about the background and session objectives.
Good afternoon. Thank you for the invitation, and it's a great pleasure and honor to be here in person today to talk on the topic of ultra-low contrast PCI in chronic kidney disease. These are my conflicts of interest. So the session objectives is to give an overview of chronic kidney disease and coronary artery disease. Contrast-induced AKI, what used to be known as contrast-induced nephropathy, how important is it? How does that affect the prognosis, morbidity and mortality of patients? I'm going to make an argument for reducing contrast to improve outcomes. What X-ray tools can help to reduce outcomes? Physiology and imaging tools with case examples will be covered by Professor Dudek, and I will give a step-by-step IVUS co-registration demonstration with some complex case examples, and finally we'll have a summary. So we know patients with chronic kidney disease generally do worse when it comes to coronary artery disease. They seem to have a more complex pattern of disease with worse outcomes in morbidity and mortality. They seem to have more coronary artery calcification, and they generally present with more atypical symptoms. But what happens in real life? So if you're faced with a patient like this who's had an end STEMI, who's diabetic with CKD stage 4 and moderately impaired left ventricular function, how would this patient be treated by you? And would they have medical treatment in the first instance, non-invasive assessment, or would they go for angio plus or minus? So Glenn Chertow looked at this, and he looked at patients with end STEMI, and what he found is if you had CKD, you were half as less likely to get invasive assessment, yet your mortality was twice as high. However, of the patients with CKD who did undergo invasive assessment, the mortality was reduced by 50%. So there may have been some self-selection there. But that was in 2004. Has things changed much? Well, multiple studies have shown similar sort of trends where you've got this bias against patients with CKD. But do these patients benefit from revascularization? So we know even patients with quite severe renal disease benefit from undergoing revascularization. So we talk about contrast-induced AKI, and contrast media can affect the kidneys in a number of ways, releasing vasoactive substances that cause ischemia of the medullary cortex, and the contrast in itself is viscous, and this can cause swelling of the tubules, all leading to contrast-induced AKI, but there are non-contrast factors associated as well. So if you've got worse baseline kidney function, your outcomes are worse, and you've got a greater chance of getting contrast-induced AKI and a greater chance of ending up on dialysis. Does volume matter? So this study looked at the ratio of contrast volume over creatinine clearance, and the sweet spot is around 2. So if you've got creatinine clearance of 30, once you give them over 60 mils of contrast, your incidence of contrast-induced AKI goes up significantly. What about prognosis? If patients with pre-existing CKD develop contrast-induced AKI, the mortality is 25% at 12 months, and the curves continue to diverge looking at other studies. So can we do anything? So this was the ultimate CKD study and showed that generally patients do worse in target vessel failure if you have CKD versus those that don't. But if you're to use IVUS in the group of patients with CKD, their outcomes are very good as though you haven't got CKD. So are we justified in avoiding these patients because of our fear of dialysis? The reality is this group of patients are going to continue to grow. We've got a type 2 diabetes epidemic, which is the biggest cause of chronic kidney disease, and we're going to have to learn to manage these patients more and more. So in summary, we know these patients have got worse outcomes and an increased risk of cardiovascular disease, less likely to receive treatment. We shouldn't be denying them invasive assessment and treatment for fear of contrast-induced AKI. It does carry a worse prognosis if you end up with contrast-induced AKI, and now we're going to demonstrate some steps to ensure that we can offer revascularization when indicating and avoiding contrast-induced AKI. Thank you.
That was a great introduction and setting the stage. Ahmed Khashaba, ultra-low contrast tools and techniques in the cath lab.
Yes.
We see the tools first, then we see the cases. You're absolutely right.
Okay, Mr. Chairman, dear colleagues, it's my delight to be here today, and thanks for the organizing committee and Philips for having me today. I'm going to speak in this talk about some learning objectives, including the strategies to minimize contrast load in cath lab daily practice, and to share with you an overview of the available angiographic tools that help to perform these contrast-sparing procedures. Actually, the contrast management strategy starts pre-procedurally, so we have to ensure that our indication is a very proper indication to justify subjecting our patient to the contrast load that we are given, so we have to avoid unneeded interventions. And also we have to use what we have in hand before the procedures, just we review what's available angiographically, either coronary angiograms or CT angiograms, especially in patients with complex anatomies like post-CABG or patients with multiple previous interventions. Pre-procedure hydrations is of an eminent importance, and we should set the procedure a time out based on a contrast time out based on the baseline patient characteristics in terms of eGFR, creatinine, and other factors that we might consider. During the procedure, I can share with you some of the tips that I use to reduce the volume of the contrast during the procedures. First, you have to minimize the buffs that you give to make sure where you are as much as possible, even to eliminate them totally. And to do this, you can use some fluoroscopic markers like the calcium, like the clips if the patient has a previous surgery, and other markers that can help you to diminish them to the minimum. You can make sure that you already cannulated the coronary arteries by injecting 20 cc's of saline, and watch for the ECG changes, so you make sure that you're inside the already probably cannulated. And you can also check with your wire if you are going directly for PCI to check for the course, and your wire will tell you where you are. You can also plan for the fewest possible injections, and you might consider some contrast dilution, and in some studies they could manage to dilute the contrast by 50% and they still get some good images. Also, this is not the case in every situation. One of the contrast waste, I can say that you give the patient the waste of contrast without making benefit, is the dead space inside the catheter. You all know that in order to fill the catheter and the contrast to reach the coronaries, you need to fill the diagnostic by at least 2 cc's, and the guiding catheters by 3 to 4 cc's of contrast. And while you are changing the contrast, you simply push this contrast inside the patient when you insert the guide wire to change the catheter. So this is a totally unneeded amount of contrast that you deliver the patient for no benefit. So you have to get rid of this amount of contrast before you change the catheter. Also, optimum vessel engagement. Make sure that you make best use of the contrast that you already deliver. No point of putting the catheter away from the ostium, make the contrast flow in the aorta without no benefit. Also, there are now concurrent tools that enables you to do the procedure with the minimum amount of contrast that you can use. Namely, the automatic injectors have been proved in many studies to minimize the amount of contrast delivered. And let me detail some of the tools that we use nowadays in the cath lab to achieve that target. We'll start with the dual-axis rotational angiography, the dynamic coronary roadmap, the enhanced device detection tools. You all know about the stent boost, but now we have also the live stent boost. And of course, the intracoronary diagnostics in terms of ultrasound and pressure wires provide a great tool for minimizing the amount of contrast, and these last two items will be discussed in details with my colleagues in the next talks. So I'll start to show you the dual-axis rotational angiography, what we call a cardiac swing, and this is a motion of the C-arm that produces LAO-RAO and a cranial caudal movement in a single acquisition for the whole heart, for the whole coronary tree, and allows for visualization of the whole tree with a single contrast injection. The views that this swing takes are already pre-planned to reduce the misinterpretation caused by the vessel eccentricity and reduce foreshortening and overlap and still give you a very good image quality. This is one example of a patient who presented with a chest pain, positive stress test, and chronic kidney disease stage 3. And we managed to image this left coronary system with only, you can imagine this takes only 7 cc's. The swing in the left system takes 5 seconds. The recommendation by Philips is to do it by 12 cc's, but this injection was taken with only 7 cc's. So we reduced the amount to half of the recommendation, and you can get a very clear image of the left system. The right system swing takes 3.7 seconds, so namely 4. So we do it with 4 cc's only of contrast. So you can take a full image of the whole coronary tree in 2 injections amounting up to 11 cc's altogether. And this is the injector, automatic injector settings. I put it at 1.3 cc per second for 5 seconds, a total amount of 7 cc's. This cardiac swing has been tested in a randomized trial, comparing it versus the conventional coronary angiography in population with high prevalence of coronary artery disease, and it was found to be safe and resulted in significant decrease in contrast volume and radiation dose in that study. The second technology that I want to share with you is the dynamic coronary roadmap, and this technology provides real-time motion compensated overlay of a highlighted coronary angiogram, and it overlays it onto the 2D fluoroscopic image, thus creating a colored map that adjusts automatically to the original coronary tree and provide continuous and specific visual feedback on positioning the wire and the catheters. Thus, it integrates fully and seamlessly in your workflow. You don't have to do any extra work to have this, but it is already embedded in the coronary flow. And from the previous rotational cardiac swing, you select, it gives you all the angles while it is rotating. So you select the best angle, detect the angles itself, and then go directly to this view. Have one more shot. This view has been taken with only 4 cc's. 2/4 in the settings of the injector, and then after you press the angio again, you get this roadmap. So you have your coronary tree overlaid without any more contrast given. This enables you to push the wire, and if you advance your wire, you can see as if you are injecting continuously contrast. And you can adjust your wires, avoid side branches, cannulate past the lesion, and place your wires where it should be at the end. And as you can see here, you can drive your wire flawlessly down the coronary artery. IVUS is an invaluable tool in this subset of patients, and in a randomized trial, the Mozart randomized trial, it has been evaluated in terms of contrast saving, and the recommendation of the trial is that thoughtful and extensive use of IVUS as the primary imaging tool to guide PCI is safe and markedly reduce the volume of iodine contrast compared with angiography alone. This is very well documented, and the IVUS co-registration is also a very good tool, but for those who don't have the co-registration yet, I can share with you a tip that with simultaneous use of IVUS during stent implantation. So you push your IVUS catheter beside the stent, and you adjust the stent with the marker on the IVUS catheter. This will become, of course, on the expense of a large caliber guiding catheter. You need an 8 French for this, but you can do this especially if you are dealing with a complex and extensively diseased vessel. The last tool that I can share with you is the live stent boost, and this is a stent enhancement technology. So after you inflate your stent, you deploy your stent, of course you will need to optimize, and this will help you to get a very good, as you can see here, a very good stent enhancement and visualization, and help you to quickly verify the positioning of post-dilatation balloons, help you to add more stents, adjust the edge to edge, and to confirm that the stent is fully expanded in a very nice way without using any more contrast. Finally, we end up with one rotational angiography as a final shot for the same patient with another CC. Make sure that you are avoiding any complications, making sure that the side branch is okay and everything fine, so you can discharge the patient from the cath lab. So my friends, my take-home message for today is that ultra-low contrast PCI is a planned rather than a random procedure. You have to plan it beforehand. And this requires a change in the contrast management mindset. You have to plan and change your habits in the cath lab to achieve this goal. And this should not be restricted to patients with coronary kidney disease, because I believe what I call the renal reserve. Each patient we have, even if he has a normal kidney disease, the contrast you are giving reduces his reserve. So further down the road, he might suffer from chronic kidney disease if we didn't take it from the start. And many cath lab tools are now available and can favorably impact your ability to perform patients in these subset of patients. Thank you so much for listening.
Excellent. And of course, the technology displayed is mainly Philips, who are the sponsor of this session. Now we move on to Darius Dudek. And he will give us some case examples of how to do imaging and physiology in ultra-low contrast PCI cases.
Welcome to everybody. Today I would like to show our experience with this concept of ultra-low contrast PCI. I would say that we have, of course, the different strategies to decrease the risk of contrast-induced acute kidney injury with pre-procedural interventions, more specific device-based interventions. However, today in our session, we are more focused on contrast sparing strategies and other strategies, and the use of coronary imaging and physiology to achieve this goal. Of course, for a few years, we are aware of some clear techniques for the contrast sparing, including the lower size catheters. We can use the previously recorded angiograms. We should use the low volume of contrast, even diluted. And also we can use different tricks with wires and ultrasound to confirm our position. Moreover, we should use with the high-tech angiographs the enhancement techniques to see the stent struts, to see the expansion and the position of the stent. Also, all the time we should remember that with the newest angiographs, it is a balance between the contrast use and X-ray. So if you have the good quality X-rays, you can increase even the rates of the frames per second and very precisely see the stents, and you don't need to use so frequently the contrast. Moreover, the new CAD labs are equipped not only with the regular contrast analysis of angiogram, but rather you can have the dynamic 3D roadmaps and additional tools which are ultrasound, physiology, and OCT to allow you to go to ultra low contrast use PCI or even zero contrast PCI techniques. A few years ago, together with my colleagues from Poland, we published the article, which is a good example that you can enter with the guiding catheter the coronary artery, and you can see using the ECG that you are really inside of this artery. Here's the example from that publication that you have the previously recorded the right coronary artery angiogram, and you can use two wires to mark the positioning, what to do and where to place your stent. And below you see the examples with the ultrasound use of the positioning of your stent using the wire and the second wire, and to allow you to implant the stent to check with ultrasound without any contrast injection. Okay, maybe for the last injection to confirm that you are done. Moreover, another operators can use the few wires to mark the side branches, and especially after the stent implantation, when you see in good angiogram, an angiograph, the stent struts, so you have better recognition of the morphology and anatomy of your vessel, and you know what to do, even without using the contrast. As I said, that those contrast sparing strategies and the use of different techniques is associated nowadays in advanced lab with the use of intracoronary imaging and co-registration. Again, we started a few years ago that with the ultrasound and OCT, we recognize in interventional cardiology that you can use those measures to better see stent expansion, malaposition, and good positioning using those techniques, because we know that there are more and more publications which showing that use the PCI guided procedure by imaging provides usually better outcome for our patients. So why not to use them also for positioning and not only for the checking the final result. Moreover, the current technology are really low profile, and as you see, you can use the ultrasound catheter and stent and to go with two wires and to position your stent without any contrast use. Moreover, you are just not only positioning, but also, as I said, checking the expansion and the position of the stent, so you can be really sure of your final result, I would say with more precision than even using the contrast angio-guided procedure. There are some, of course, step-by-step approach, which are very clear, but basically you are just positioning the ultrasound on the target area, you mark with the wire, and then you implant your stent, and then you can go inside with your second wire again to the stent, and you can check your final result. So as you see, even optionally as the step number 8, you can use just 1 2 milliliter contrast or even echocardiogram in the cath lab to be sure that your result is good one. Moreover, as I said, you have also some opportunities with the new generation angiograph using dynamic coronary roadmap. Moreover, you can use the combination of the dynamic roadmap, you can use the fluoro, you can use the co-registration and combination of the angiogram, and you can use the combination with the ultrasound and physiology assessment, which is intracoronary. So I would say that this is a good example that with the one baseline angiography, diagnostic one, you can use the roadmap for your PCI procedure with another guiding catheter if you don't move the table and you have the same projections. You can use this technique for right or left coronary artery. And you can use, of course, not only the wire for stenting, but also you can use the physiology wire to assess the severity of the lesion and to know if you need to do any kind of intervention. Here IFR was 0.93, so no need for intervention. If you go with the even the scout technique, so you can do the pullback with your physiology wire, and you can map the vessel, where is your target area and when to put your stent if needed. So of course this is some learning curve based on the preliminary experience. However, it's not so difficult, and in majority of cases you can really go with the easy way, the coronary wire, to position your wire without contrast injection, which is the very important. I would say that we are saying that there are some possible more application for this technique with the wiring of difficult anatomies of complex PCI is possible. There are some preliminary experience on the balloons and stent positioning with the technique. It could be that the side branch occlusion after stenting probably is the best possible tool to guide the access to the occluded side branch after stenting. And for the CTO recanalization, the visualization of the distal vessel could be very helpful. With my colleagues, Professor Rzeszutko in Poland, running the study, which is based on the physiology evaluation of coronary vessel, and the baseline angiogram is based on the DCR map, and then the IFR is inserted, and of course no adenosine used because we are using just IFR, so you don't need to use the hyperemic simulation. And then this technique is allowing to assess the severity of the lesion and plan your procedure, and also it could be used with ACS patients. But I would say that looking for the newest technology, the combination of angiography and ultrasound and physiology gives you additional opportunities for your intervention. I would say it's a kind of pre-procedural planning and intra-procedural monitoring with the advanced imaging and physiology assessment. And a few years ago, we started with the co-registration of the angio and ultrasound, which gives you the very good understanding where you are, what you can see and hear. We're just evaluating the stents. You see very precisely, much better of course with ultrasound than with angiography. Then we started to use the combination of the registration of physiology assessment and angiograph, and to map the vessel to know where is the tight stenosis and when is your potential virtual stenting possible to translate into the real stenting, so to just map the target's area for causing ischemia. And finally, I would say that the best of the best is, of course, the combination of the angiogram, ultrasound, and physiology, because you know if to treat, where to treat, and then you can check with ultrasound the precision of your intervention, probably improving, the outcome of our patients. And of course, more studies are needed. However, there are very convincing data. Of course, as we see in the newest publication will be today discussed, is the use of ultrasound co-registration and the very detailed protocols. So it means that we have the confirmation in US literature that we have the very important step forward with those techniques. So I'd like to conclude that the new techniques for contrast sparing and newest imaging technologies allow to perform ultra-loud contrast PCI in well-equipped CAD labs. And the use of physiology and imaging co-registration with angio, I would say, adds additional opportunities to perform these PCIs and can be used to perform complex PCI, I would say, including left main bifurcation stenting with good results. We are just much better nowadays with our interventions. Thank you very much.
Thank you, Darius. That was a great run of examples and stepwise detailed approach. So we have one more talk and then we have time for some questions and answers. Bilal, you want to tell us how to use IVUS co-reg in ultra-low contrast PCI in complex coronary artery disease. And you've got 10 minutes for a step-by-step approach.
We did have some technical issues, but I'm hoping they've been sorted out now. So I'm going to go through step-by-step ultra-low contrast PCI with some complex cases. So this is a 75-year-old gentleman, type 2 diabetic, with cirrhosis and non-alcoholic fatty liver disease with portal hypertension. CKD stage 4, EGFR is less than 30. He's had recent COVID infection and has had 2 NSTEMIs in the last 3 months medically treated. Important because often that's what happens to this group of patients. This was his ECG. And this is the angiogram. So there's a chronic total occlusion of the right, but there's tight calcific stenosis seen of that proximal LAD. So he went for heart team discussion, high risk for surgery. His risk of developing contrast-induced nephropathy was 26%, assuming 100 mils of contrast use. The patient was accepted for high-risk ultra-low contrast PCI. So the question I'm going to ask the audience is, if you were to do this case, how much contrast would you use? Just hold that thought. So this is how we do these cases in the cath lab. We've had an angiogram taken at a previous time. We will print them pictures out and place them under the screen as seen there. And we will use the same views that we have that show the lesion the best. So often we will print 3 pictures out and use exactly the same angles for the radiographer. Guide engagement is done without contrast. So here we can see calcification of the left main stem, and as the guide is being engaged, often you will know by the calcium how the guide feels. Sometimes, as Darius explained, you can give 20 mils of saline, look for ECG changes, and you can probe with the wire. If there's osteostenosis, you'll see pressure damping as well. And then wiring of the vessel. So here we see the outline of the vessel because the vessel is heavily calcified and we're just following the vessel down, but we've also got our printed out roadmap. So far, no dye has been given. Here we went for upfront rotational atherectomy with a 1.5 millimeter burr, and after that we perform our IVUS core registration. So this is performed by doing a manual IVUS pullback with the eagle eye catheter, continually screening. And the software will then co-register. So now we're doing our pullback, and once we've done the pullback, we are co-registering against the wire. The wire is the surrogate for the vessel. So here we are manually tracking the wire, and once we have done this, when we review the images, what we see is where the yellow marker is corresponds to the IVUS image. And we see that there's still 270 degrees of calcium seen, and in the bottom left there's nearly 360 calcium. So this is going to require further calcium modification. Here we employed the concept of targeted calcium modification with IVL, targeting 3 specific areas with 20 to 30 shocks, because there's 80 shocks in the balloon. And following this, we repeat the IVUS run, and the post-IVL run very nicely shows areas of fractures in the calcium now allowing us to go ahead and deal with our angioplasty and stenting, quite confident that we'll get a good result. So the core registration can help guide stenting as well. So we've got your distal landing zone, you see a good area, you can measure the length of vessel, this is often accurate to 1 to 2 millimeters, and you can look at your proximal landing zone as well. So here we're going to need 2 stents. The distal stent will be a 3.3 millimeter stent, and the proximal will be a 4 millimeter stent. So we stent the mid-LAD first. Now, stenting the proximal LAD is quite tricky here because we need to land the stent away from the ostium. We don't want to land it at the ostium, so here we deploy a small undersized balloon in the circumflex and use this to position the proximal LAD stent. We post-dilate and then do our IVUS run, and the IVUS shows there's a little bit of eccentricity, but generally you've got a good stent expansion with a good minimal stent area here. So the question is, do we do an angiogram at the end? Our practice is that we would do 1 angiogram at the end just with 5 mils of contrast. And this is the angiogram done at the end, a single shot, and the main reason is to look for any complication, particularly distal vessel perforation. So can we treat left main with ultra-low contrast PCI techniques? This was an elderly lady who presented with an end STEMI. She was a surgical turn down. This was the angiogram done a few days previously, and you see tight calcific distal left main stem disease here. There's also disease of the circumflex. She's turned down for surgery, and the question here is, if you were to do this case, how much contrast would you use? She had moderately impaired LV systolic dysfunction as well. So we used the techniques previously described. We wired the LAD. We decided to go for IVUS. After ballooning, we did a scoring balloon and then IVUS. We were not keen on using rotational atherectomy here and had to put an intra-aortic balloon pump up front. The IVUS top panel shows the ostium of the circumflex, so there's no disease at the ostium of the circumflex. Therefore, a provisional approach will be fine here. The bottom shows fractures after the scoring balloon. So we stented the mid-LAD here, and then we stented back to the ostium. So how do you stent the ostium of the left main using no contrast? We use something called the floating wire technique, a wire in the aorta. You push the guide up and then pull back by 2 millimeters, and then you deploy the stent. So this works quite well unless you have a horizontal aorta, in which case you have to be careful, and this is where you may need to give a single injection of dye. So after stenting and post-dilatation, this was the angiogram done at the end, and this was the IVUS. So we see an IVUS here of the LAD, well expanded, IVUS of the left main stem, and here we see the circumflex in the middle panel where the star is. So we didn't open the struts here. In somebody elderly, mid-80s with this pattern, we want to get them out on the cath lab quickly, and we don't want them coming back in hospital again. So that case was done with 6 mils of contrast. Now, can we do even more complex cases? So this is somebody, again, with CKD, peripheral vascular disease, end STEMI, widespread ischemia with moderate to severe LVSD. And this was the angiogram. So we see there's quite severe distal left mainstem disease, proximal circumflex disease, and disease seen in the LAD as well. Once again, these are the sort of patients that get turned down for surgery. It's the most commonest cause for surgical turn down is CKD. So how much contrast would you use if you were to do this case? Again, just hold that thought. So here we went for a 7 French radial strategy. We couldn't use impeller or intra-aortic balloon pump because of peripheral vascular disease. And we said we'll do an upfront ultra-low contrast 2 consultant case with calcium modification. We used the 1.75 burr. After doing the rotablation, we IVUSed, and the IVUS shows us the proximal distal landing zones. And we thought we dealt with this with a DK crush technique. Stented the mid-LAD first, then did all the steps of the DK crush without giving contrast. So all the steps are done. You got your first kiss, stenting the ostium of the left main, again using the floating wire technique, your pot, recross, second kiss, final pot. And then this is the stent looking at the circumflex of the left main stem, LAD seen on the top right-hand part with the white star, and LAD to left main, circumflexing with good clearing of the struts, as you should get in a good DK crush. So this was the final angiogram, and only angiogram done in the case, and that case was done with 4 mils of contrast. And this was this gentleman's echocardiogram before and 4 months afterwards, showing good improvement of left ventricular function. So is it reproducible? So we've just recently published our paper on left main series, and this was another patient with tight distal left main, and this patient had, as we were putting him on the cath lab table, quite marked hemodynamic instability, and we put an intra-aortic balloon pump in first, and again in this case we were able to repeat a DK crush procedure, only giving a single injection at the end of the case. And this was the IVUS looking, again showing good clearing of the struts. So when do you need to inject? So this is not about how low can you go. You have to be safe. So we inject when there's hemodynamic instability, if there's ECG changes of ischemia that can't be explained, if there's any arrhythmias that can't be explained, or chest pain that can't be explained. You may also want to inject when in doubt. And this is really, really important because the aim here is to reduce the amount of contrast you're using in this very complex group of patients. But you don't want to be at a stage where you're actually causing harm. So question again, how much contrast would you use for this case? So when we look at these studies, DK Crush 3, DK Crush 5, and EBC main, in all of them, they were using close to around 200 mils of contrast. Taken, if you know the patient's got CKD, you'll probably use less. However, this is a group of patients, traditionally, we think you'll use large volumes of contrast. It's possible to do these cases, reducing the amount of contrast. Reducing risk is multifactorial. Contrast is a small part of reducing the risk, but it's part of the bigger picture for the patient. And these are other things that we need to consider. So again, it's not how low can you go, it's as low as is reasonably possible. You want to balance the risk to the patient of contrast versus the risk of doing a procedure where you will cause the patient harm by not giving contrast. And if you get things like hemodynamic instability, drops in blood pressure, this in itself can also cause contrast-induced AKI as well. So if you're faced with this patient again, would it be medical treatment, non-invasive assessment, or angio plus or minus using ultra-low contrast PCI techniques with IVUS? In conclusion, CKD patients are disadvantaged. Intracoronary imaging with co-registration is a useful technology to reduce contrast. Complex PCI, including left main bifurcation and rotablation, is possible. It allows us to offer interventions to the highest risk patients and reducing the risk of CIN. It's not how low, but as low as reasonably possible. It's not just about the contrast, and the scale of the problem is going to get bigger with the increasing epidemic of type 2 diabetes and CKD. Thank you.
Bilal, that was fantastic talk. I mean, a whole toolbox has opened up on what you can do without contrast. Why do we need contrast anymore? Fantastic. Darius, up there in cyberspace, any comments or questions for our speakers?
So first of all, I would like to say that it's very interesting that during this 30 minutes, we presented that today, if you think about the CAD lab of 21st century, which we like with Andreas to say about the pre-procedural planning and intra-procedural monitoring for coronary or structural interventions, you need to select the appropriate devices. And I would say when you consider today, not just have the angio good or one with CNET, but rather the software, which is giving you a dedicated opportunity. And don't think that you need just ultrasound, OCT, and FFR or IFR, but rather you think how to integrate. So for you, it should be sensitive. Which patient are you going to do? Which technique are you going to use? And as you see, some companies could provide the co-registration, which is very important, and give you opportunity to combine those techniques to give you what was in near past not possible to do, as you said, Andreas, almost without contrast or sometimes without contrast, the PCI procedures.
Fantastic, yes. You know, I learned a lot in this session, I must say. And some of the things that we can do are actually quite easy. So let me ask around in the audience, 2 questions you'll get. One is about a simple thing. Who uses contrast timeouts? I.e. you define a level of contrast volume that you will give and then you will try to stop. 1, 2. I think, Jean, you always have this calculation, right? I call it the Toulouse formula. It's EGFR times 3, I think. So if you have an EGFR of 30, you're allowed 90. So 2 out of the here use that formula. We do sometimes. And then who actually has a dynamic roadmap in their cath lab available? 1, 2, that's even more, 3, 4. But I think there's so much we can do, and I do agree with the last speaker. It is becoming, it's increasing as a problem. There's more and more patients with these chronic kidney disease and low eGFRs, and we want to treat them, not like in the old days, just ignore their coronary disease because the kidneys wouldn't allow an angiogram. Are there any further questions for us?
Yeah, if I may have a comment.
Andreas, maybe I will be more specific that our ultimate target is not just to use the lower amount of contrast, because this we know from the past. Our ultimate goal is to use contrast only for final injection or even at all. So all those tools, co-registration, all those techniques and technology should give you the opportunity to do PCI without contrast. This is our goal.
The ultimate goal.
Thanks. Thank you very much. You know, I work in a very poor setting, and I've learned a lot. I'd like to very quickly share what we do, because we don't have any of those equipment except IVUS. So we actually plan our procedure really well, because you know the Mike Tyson quote is everybody has a good plan till you get knocked out in your face and then your plan disappears. So if you cause an edge dissection or something like that, all your plans are going to disappear. So we plan our procedure really well in those patients. We should do that for every patient, but we don't. You know, we sit and put a really good plan for those patients regarding sizing, what we're going to do. You know, plans don't change unless we have to. We stage cases, so we don't do a lot of, you know. We use a 3 cc lower lock syringe with dilute contrast with all the new, this is a Chris White's advice, and it works. And we use small amounts of contrast and 5 French catheters, sometimes even a microcatheter for a little puff. Everything is on fluorosafe, no puffs without, you know. So we use the sort of cheap, poor man's tricks, and they also work. But of course, a lot of IVUS. IVUS is the game changer. This has been a fantastic session. Thank you very much.
Excellent comment. Thank you.
The only comment I have on the definition of ultra low contrast. So with these calculations, with the 3 times the eGFR is a low contrast, but it's not an ultra low contrast. And the definition on most of the studies about ultra low contrast is only 1 per eGFR unit. So eGFR multiplied by 1. So particularly in the very sick patients who does not tolerate even this relatively large amount of contrast, if you use this formula for the 3 by GFR.
Short question.
One short question.
One very short question. Recently, even the idea that there is something called contrast-induced nephropathy has been challenged, and also it has been proven that hydration in a randomized trial has no value. Your comments?
Can I take this one? Yeah. So it's been challenged because a lot of the studies looking at this that challenged it was looking at intravenous versus intra-arterial. We definitely find in patients undergoing coronary procedures, the risk is there. Nephrologists would say the risk is not as great as we are scared of that, which is a valid point. However, when you've got patients with very poor baseline eGFR, when we're doing the sort of cases that we've demonstrated, we're giving them a lot of contrast will significantly increase their risk of contrast-induced AKI and ending up on dialysis with a significant outcome in morbidity and mortality. So that debate is there with the nephrologists, but there is some important nuances with the evidence there.
That's satisfying, yeah. And we've all seen patients go tip over, right, with bad kidney function, contrast, and then they go over to dialysis. We've all seen it, so, well, I believe it, actually, is the answer. In summary here, chronic kidney disease patients are out there and they are different, but they deserve the treatment in ACS particularly, like all the others. We learned many procedural tips here. Many things can be done easily, like contrast timeouts calculation and the IVUS and the wire techniques. Some require technology, and we've seen fascinating new technology like the dynamic roadmap that will enable us to finally achieve the goal of having an angioplasty done, even a left main, with very, very, very low contrast or no contrast at all. So this is the end of this session. Thank you to the speakers. And again, I learned a lot thanks to the sponsor, Philips. And we swiftly move on to the last session, the highlight of every congress, the complication session.
Thank you.
Thank you very much.